Hello everyone. In this video, I am going to discuss a very important topic, that is cerebral venous thrombosis. It is also called as cortical venous thrombosis. Remember, it accounts for nearly 0.5 to 3% of all strokes. Whenever the word cerebral venous thrombosis comes to your mind, the first thing which comes to your mind is the most vulnerable populations are young individuals, women of reproductive age group, and patients with a prothrombotic or hypercoagulable state. So it is nothing else but CVT is the presence of blood clot in the dural venous sinuses, and it is a type of stroke, okay, but only 0.5 to 3%. Remember, less than 50 years of age is the most common age group, and always remember the incidence in female is very much higher than that of male. Patients with cortical venous thrombosis have a favorable outcome. They all survive without any physical disability. But remember, certain prognostic factors decides the severity. That is, advanced stage active cancer, decreased level of consciousness, intracerebral hemorrhage are the poor prognostic factors. Coming into the incidence, okay, that is which veins are more prone to have this thrombosis. Remember, it is always transverse sinus, because nearly 60% of the CVT occurs in the transverse sinus, number one. And number two is the superior sagittal sinus, which is around 25 to 45%. Then comes cortical veins, straight sinus, and the deep venous system, and nearly 10% occurs in the IG. So this is about the distribution of the cortical venous thrombosis. Coming into what are the predisposing factors, or what are the etiology or the risk factors for CVT. Number one, oral contraceptive. Number two, pregnancy postpartum. Number three, hormone replacement therapy. Next, head and neck infection, dehydration. Remember, CVT is very common in severely dehydrated females postpartum. Okay, whenever I was a house surgeon, I came across a patient who has been diagnosed with cerebral venous thrombosis, admitted in OG ICU. Okay, the reason is she hesitates. There is a taboo which still prevails in the village areas in our country, that we should not take water or other fluids after delivery, especially for those females who are having who undergoes home delivery. Okay, yeah, delivery at their home without any proper awareness and all, and okay, they are very well prone to have developed this cortical venous thrombosis. Okay, it is very saddening thing. So then anemia, sepsis, respiratory infections, then drugs like corticosteroids and tamoxifen. Remember, asparagines, thalidomide are very rare, but corticosteroids and tamoxifen are very common. And remember, malignancy like myeloproliferative disorders, antiphospholipid antibody syndrome, that is very common. Okay, the incidence of CVT in APLA is very high, nearly 6% to 17% of cases of CVT is because of APLA. And then other prothrombotic states like prothrombin mutation, factor V Leiden mutation, that is the most common hereditary cause of hypercoagulable state, then antithrombin deficiency and more. And then coming into head trauma, neurosurgical procedures, then jugular vein catheterizations, and so on. Then coming into the clinical features or the clinical presentation of CVT, it is mainly because of the intracranial pressure, raised intracranial pressure of the focal parenchymal injury, and the most common symptom which occurs in nearly 90% of the cases, it is headache. Then other symptoms are nausea, transient visual obscurations, visual loss, papilledema, diplopia. Then seizures can present permanent neurological deficit, which occurs in nearly 20 to 50% of the patients. Encephalopathy and coma occurs in less than 20%. And remember, some cases will have like an acute presentation, like a thunderclap headache or subarachnoid hemorrhage or acute onset of focal neurological deficit. So these are the various clinical features you have to remember when it comes to cortical venous thrombosis. And coming into the so-called as the brain and vascular imaging. Okay, first always we go for MRI or the so-called as conventional CT. Okay, that is the first test we always do. And in CT, that too in NCCT, non-contrast CT, there is a hyperattenuation, okay, which is because of an increased hemoglobin and red blood cells within the thrombus, and this is called the most famous dense vessel sign in CVT. Okay, yes. And remember, when the sagittal sinus, there is the superior sagittal sinus. I told you, superior sagittal sinus is the second most common dural venous sinus to get involved in CVT. In that, bilateral hypodensities may occur when this superior sagittal sinus is involved. Okay, yes. So as I shown here, okay, these are the in picture A, you can see that there is left-sided, okay, C-shaped hemorrhages. You can see this is the transverse sinus thrombosis, and this is the so-called in the middle. It is a straight sinus thrombosis. Okay, yeah. And remember, the so-called as dense vessel sign, it is occurs in the non-contrast CT. It disappears when we inject contrast. Okay, then how will you confirm the diagnosis? Remember, it is always CT venography or MR venography. These are the final gold standard test. And okay, when invasive treatments are considered, we can also go for DSA. What is DSA? Digital subtraction angiography is also done. Then coming into therapeutic advances in the management of CT, remember it is always anticoagulation, anticoagulation, anticoagulation. And when it comes to anticoagulation, the treatment of choice, it is always LM. WH. What is that? Low molecular weight heparin is always preferred over unfractionated heparin, and followed by that we will do a transition, or we will shift the patients to oral vitamin K antagonist also. And recently there have been lots of evidence-based trials, okay, regarding the use of DOAC. What is DOAC? DOC, that is direct oral anticoagulant. The RESPECT is one trial. Then we have the secret trial. In all those, they say that DOAC are good. They can be used in the treatment of cerebral venous thrombosis, except in the following groups. What are the groups? That is malignancy, central nervous system infection, trauma, pregnancy, and all, because there is very high because in these conditions the risk of thromboembolism is very high, because all these are hypercoagulable predisposing conditions. So in these cases we should only use low molecular weight heparin, especially in antiphospholipid syndromes and all. We have to use LMWH, okay, or with warfarin. But the DOACs is not indicated in Apla syndrome and all these groups I have mentioned. So whenever there is a clinical suspicion, we do brain and cerebral venous sinus imaging, CT, which is usually combined with MRI first, and the gold standard is CT or MR venography. And coming into the risk factors, as I told you, we have to etiologically evaluate, okay, use of oral contraceptives and laboratory test, all the hematocrit renal function test, then all the prothrombotic test, that is to assess the hypercoagulability, has also been done. And remember, always we will do, once the patient is stable, we have to start with always low molecular heparin. That is the first treatment. Subcutaneous low molecular heparin is preferred over, or if it is intravenous, means we can go for unfractionated heparin. But remember, low molecular weight heparin is always preferred than unfractionated intravenous heparin. And even endovascular treatment, so-called the reperfusion therapies, also has known to be effective. And when it comes to cortical venous thrombosis during pregnancy and puerperio, because I told you the incidence of cortical venous thrombosis is very high, okay, very high during pregnancy and puerperium states. In this case, what happens? What drugs should be used and what should not be used? Remember, warfarin should not be used because of the risk of fetal embryopathy. Hence, it is contraindicated in pregnancy. Hence, low molecular weight heparin is used in the majority of treatment. And remember, the duration where we have to prescribe a low molecular weight heparin is around 3 to 12 months. And as I told you, DOACs are appear to be safe and effective, as well as based on the new evidence-based trial. But there is a few exceptions in certain groups where we should not use Apla syndrome, malignancy, CNS infection. In that, always it is low molecular weight heparin. Thank you.